Welcome, everyone. So today it's the second DRTB alumni meeting that you're joining. This time it's about being aware of false Xpert MTB RIF results, nationwide results from Rwanda. We have a very nice intervenant over here. It's Claude Simuto. He's going to present some interesting stuff. He's a scientist at Rwanda Biomedical Center in Kigali, Rwanda, and also a scientist at microbacteriology unit at the biomedical science department at EM. We have different moderators today. So first you have Bouke de Jong here. She's the head of the microbacteriology unit at biomedical science department at ITM. Then we have Anita Messick over there. She's a scientific fellow of the HIV TB unit from the clinical science department at ITM. And then you have me. I'm a scientific assistant from the microbacteriology unit of Bouke de Jong also at ITM. So first I'm going through some practical organization. So this session will last along 1 hour. This meeting will also be recorded and will become available afterwards. If you would like to have a copy, you can send me an email, but it will also become available on the alumni platform. Then the practical. So after this, I'm going through some housekeeping rules, just that you are informed how you can ask questions and how you can unmute yourself. Then Claude will present his presentation, and afterwards we'll have some discussion time. So some housekeeping rules. As you might have noticed, everybody is muted in the start because we want to avoid the background noise and interruption of the presentation. So if you have a question or comment during the discussion, you can ask us by going at the right bottom. You see reactions. You can raise your hands. And then if we give you the floor, you can unmute yourself and then lower your hand again. Also, if you got something interesting to say, don't want to say it out loud, you can just use the chat function. So now I give the floor to Claude. Claude, you can share your screen.
Okay, thank you. So thank you, Sari. Thank you all for attending this presentation. It will not be too long. It's just highlighting some of our recent findings about false result on Xpert MTB RIF. That is the classic Xpert. As you know, Xpert gives two important results. One, detection of TB and detection of rifampicin resistance. So those two important results are always given together. And what I'm going to present here, we concern both results. Importantly, more rifampicin resistance, but also some false TB. So you are clinician, most of you, and I know you like cases. So we start with cases. One of our real case is a case where during active case findings among people with HIV, an old woman, the SAT8 woman, had been tested, but she didn't have any TB symptom. She didn't have any TB history. And it was kind of era of the healthcare workers where they just erroneously deemed the case to be eligible for Xpert, yet it was not, because in Rwanda, the guideline is that among HIV positive or other high risk group, the Xpert is only done when there is at least one symptom or chest X-ray shows some suggestive. So that is when Xpert is requested. For this case, it was something wrong with them. The patient was invited to the closest health facility, health center, and she was deemed eligible for the Xpert was done. So the Xpert showed rifampicin resistant detected, as you can see, and high MTB. As you know, I will show you how does this work. Normally, the experts, I will come back to the how it works. So the patient, because the rifampicin was detected, the patient was sent to the MDR TB clinic, where she should start treatment. And at MDR clinic, they took other sample and repeated Xpert, then it turned to be negative. That was really something that triggered the extensive analysis that I will show. One is the second Xpert was also TB not detected, and the smear was negative for both slides. And later, the culture also was negative. So the case, as you see, we had to analyze what really was wrong with the initial Xpert. We have seen that the Xpert signaled or give the positive result, the positive TB result, based on a low cycle threshold. I will explain this. The cycle threshold, the Xpert cycle threshold, is like the Xpert or other qPCR, quantitative PCR, or real-time PCR is a bit different from what used to be conventional PCR in way of when does the machine read the product. For Xpert, the reading of the amplification is at real time. So when the amplification is being done, the machine also gives continue reading in such way the detection, the lowest detection, the cycle at the lowest detection level correspond to the cycle threshold. And that is inversely proportional to the amount of DNA in the sample. So when the amount of DNA in the sample is high, that CT or cycle threshold will be very low because the detection will be quick. It won't need too many cycles to detect. And when the material in the sample are very low, it will require more amplification to be detected. That is then where the CT will be too high. So for this sample, for this patient, the cycle thresholds were very low. We say 9, this is 9. 9 is very low because normal qPCR at least starts at somewhere 10. And why is that? Because when optimizing the qPCR, it is important to know because the amplification is dependent on the supplies within the cartridge. So if the cycle threshold is very low like this, there is high chance that depletion of the quite quick, and some false detection of target may happen. So we noticed that this was very low, and also we have seen that the signal for the detection was something like a peak, but which comes down again, which is not real amplification, but just false signals with abnormal curve. This is abnormal curves. So the conclusion was a false TB, and false TB with false rifampicin resistant on a patient who is already at clinic to start the MDR treatment. This was quite strange. So we worked on this and in collaboration with Xpert and proved this was really a false result. And we submitted a manuscript together with many colleagues. And so after submission, after a few months after submission, we noticed another case spotted by Eve. I think you know Eve. Eve is our MDR TB director, and when a patient is detected at any center, they send him results. And Eve, when he saw also the very low CT like this, the 9 as the previous, so he contacted me, Claude, please see whether this result is also something wrong. So when I saw the result, I say, if this is another case, so we need to really see the curves and investigate on this. So we repeated Xpert again for this patient, and were negative, smear negative, and culture is now, I think, at the latest week, not reading yet, but also likely negative, because culture positive on midget takes quick. And we also noticed that the curves were wrong because the peaks or the straight line are not typical for the function of the curve with qPCR. So this was also totally wrong. This is also another case, false TB, with resistance detected very high, and the patient also was in more context of very minor symptoms. He was coughing, minor coughing, and he had weight loss from prisoner. Both cases are well, are okay without any TB treatment. So it confirmed this was also another case of false TB, false rifampicin resistant with this high load or high bacillary load. So what we learn from this, I think you know Tom Dicro. Tom Dicro is one of my promoter. Last week we discussed, and he said, Claude, when diagnosis of TB is doubtful after a positive test, it is also doubtful whether the test had to be performed. So it's like, if you want to be really sure of the result, positive result, it's really not sure to ask for tests. So I like that comment from Tom. So whenever there is something discrepancy with or discordant with clinical aspect, please suspect a false result. Always take the context and really elaborate on that. That is the important lesson from these two cases. So I will briefly explain how Xpert works. I think you all know this figure. Xpert have like a very short target, but this short target is the most important in detecting rifampicin resistance. This is a hotspot region for mutation associated with rifampicin resistance. And it uses 5 probes, A, B, C, D, and E. And when at least two probes are amplified. Xpert, we say MTB detected. And when the CT, the psychothreshold, the lowest psychothreshold is the one to use for reference as the semi-quantitative grade. That is low, very low, medium, and high. It depends on when or the psychothreshold, the lowest value. And when there is a difference between the maximum psychothreshold minus the minimum psychothreshold, the difference is above 3.5. The Xpert, we also say rifampicin resident detected. So this is important for you to know. And when the psychos have gone up to around SAT5, and the max CT or the higher CT is above SAT8, then the difference here will not be sufficient to define the resistant status. That is where Xpert will just say rifampicin resistant indeterminate. But generally has a very good sensitivity and specificity for all kinds of specimen, most either extrapulmonary, pulmonary, even among children. It's good and it is recommended to be used. But we already know some important limitations which are by design. So that is how it works. It doesn't target or it doesn't include two important mutations. Although these mutations are quite rare, some settings may have this high, like South Africa, I think you have seen that, and Eswatini, but it is also important for your setting to really investigate whether you have this kind of or not. Another important aspect which can be problematic is this or delayed amplification. This can be affected by what we are going to see. And another important factor is sometimes silent mutation cannot be differentiated. And also heteroresistance. I think you know the heteroresistance is a mixed population where you have a portion of resistant mutants and wild type. And when the resistant mutants are in low proportion or in low amount, that is where Xpert will have a challenge to detect the mutants. So when it's really high, it's Xpert will also detect, but it also depends on mutation. We see that. So Xpert have really been used, and most of the country are really using this, and demand is high in every country. Some countries have even moved to fast diagnostic. Tell you the context of Rwanda. So what is the use of Xpert in Rwanda? So briefly, is now serving as initial diagnostic for more than 60% of patients. And in 2019, 2020, around 70% of all notified were because of Xpert. The Xpert was used as the first diagnostic for all 77% of the total notification of the country. You can understand that most of the patients or majority have really used Xpert, or Xpert have been used on most of the patients as initial diagnostic. So the status of TB in Rwanda is not such high. It is really good, 57 out of 100 million. That is not high. Also, rifampicin resistance is low, 1.5 and 100 million. And we have a very good active community health workers or system that bring the patient as earliest as possible to the health facilities. So they are close to their communities, they alert when there is a symptom, and patient can go quickly. So our previous analysis have showed that we shifted in RR diagnosis from phenotypic to LPA, then to Xpert. So in 2016, our analysis showed that most of the patients had more Xpert than LPA, and also all 100% were notified based on these molecular tools. So, and that is where we showed also that the delay in diagnostic have really been reduced, and these have been alongside or have induced or have caused reduction in mortality of rifampicin resistant. Maybe you can read on this paper. It is an interesting programmatic analysis, and it can also guide in your program on how. So the point or the data that I'm going to present to you have been collected in one bigger study that we are conducting in many countries, in many African countries, 9 countries. The study is called DIAMA, Diagnostic for Multi-Drug Resistance in Africa, where we aim to replace the standard culture based to more molecular-based management of patients. So in first work package or in one objective is really to ensure comprehensive molecular DST for multi-drug resistant detection, where we are trying to validate many rapid diagnostic tool for including the recent, the Xpert MTB XDR, which is now endorsed. So some of the data are from DIAMA, are from our study. So now we have this approved. It's good point. And not only diagnosis, but also follow-up. We know that follow-up is more dependent on culture again and smear microscopy. So we want here to use VitalStain, FDA, fluorescein diacetate, to really see whether the culture can be avoided. We can learn about failure or good progress of the treatment based on this microscopy technique. Another approach that we want to address here is Xpert value, to whether see the slope of decreasing, increasing CT, whether it can correlate or it can signal the failure. And this is the most important, and that is where we repeated always experts for all rifampicin resistant to really have a baseline CT on which we use to ensure the follow-up. We do follow-up of patients and repeat experts at monthly basis. In such a way, we could define the slope in CT that correlate with failure or success of treatment. So that is where at NRL, in Rwanda, we repeated experts for that reason. By repeating experts, we have seen that frequently many of RR were not being confirmed as RR. By repeating, we have seen that a frequent discordant result was So we decided then to go with a complete analysis of all those samples, all those patients who were not confirmed by second expert, to do like more population-wide analysis. So we considered true resistance or resistance detected on phenotypic resistance or confirmed confirming mutation. We used all type of sequencing. We used Sanger sequencing, that is one, and we used duplex on the samples or the culture-based whole genome sequencing. We defined false rifampicin resistant when no mutation was seen on with sequencing or and on phenotypic DST, and when no sequencing was available or phenotypic result, we just say this was unknown. So the results are here and easy to see. Among 154 patients considered in the analysis, only 54 were confirmed as resistant with repeat expert. So all these had a repeat expert, and only 54 had repeat resistant expert. So, and all these were confirmed as resistant with the other methods as I highlighted. And among these 54, only 4 had very low basal loads. So among 100 who were not confirmed, 67 were then or had conclusive status, and only 10 of these had resistance, and that is 15%, and 5 were detected on follow-up of, as I said, with the expert, repeating expert at monthly basis. So most of these unconfirmed or false rifampicin resistant were very low, and that was all either RIS or when TB was not detected on their feet. So briefly, when we did the multivariable analysis, we showed that being retreatment or new exposed to previous treatment, TB treatment, was not as strong as having a very low basal load. The very low basal load was the real driver of false rifampicin resistant in our population. So based on the WHO operational handbook, it's still, I think this was a bit released even after our result. It still say repeat when a probability, the probability or the risk of MDR is low. That is mostly new patients with no contact of MDR. And those with high probability, that is more retreatment patients and contact with MDR, and should immediately start treatment. Suppose this is very, this is not easy, and the guideline recognize that, the experts have really seen that false results on rifampicin are associated with a low bacterial load. It was really highlighted, but no strong action on that. So we changed our guideline in Rwanda since 2020. Since 2020, we changed the guideline. Now we are confirming all RIF resistant with low or very low basal load have to repeat experts. And when expert is repeated and resistant, the patient starts MDR. And when the repeat is either negative for TB or RIF susceptible, the patient here is started on first line regimen, while the continuous testing at monthly basis for mostly detecting the mixed population that I previously highlighted is this is the algorithm that we implemented in Rwanda. So still now we are facing some challenges with the algorithm, the complexity and so on. So in the algorithm, we say that all MTB detected low, very low should send the sample to the National Reference Laboratory for confirmation, but in most cases they don't. So of 24 with this status among SAT5 that were detected in around 60%, 70% of Xpert sites by mid 2020, 11 only had sent the sample from the site, and the 24 only 19 were repeated. As we say, please repeat for very low. Only 19 were repeated and 5 did not repeat. So this is a challenge. How do you treat without repeat? And so among the 19 repeats, 3 were resistant, but 4 MTB not detected, 11 RIS, and during the repeats, monthly repeats, only 2 had eligible already to this, but we have seen that some others were not repeated. So now the challenge is that we could likely miss some of resistance because of this complexity. So sometimes at central level, you can quickly understand the flowchart is this, but it doesn't really work like that. It really have to be as simple as possible. And this is where we are now thinking to really simplify this and make sure the central level is following all these cases. If our director of MDR is aware on this, and we are working to see how can we make it as simple as possible. So another point is that our estimates are 190 cases in 2019, and we only had 40 cases in 2020. And this curve of WHO we keep somewhere increasing, and we might have something like 200 if not. And we need to really explain this gap. What is this? What is the trend of RR in Rwanda? We need to see how can we really explain this. Are we missing this large number, or where can we really find this? What is the reality? So yeah, we need to see. So other settings, what is known in other settings? Many other studies, mainly with a small set of samples, have also showed that in Haiti in 2016, they have seen that among 14 with false, 12 wild type had a very low bacillary load. And most of these studies have all highlighted the very low with need to confirmatory. And this starts even long back in 2012 when Professor Annelies did a South Africa case report. He showed that this was a false resistant, but because it was only one case, she was not able to associate with the low basal, but basically it was a low basal load related cases. So as recommendation, it is really important to investigate the false RR among very low TB samples. So it is really important, and always see possibility of follow-up testing for these unconfirmed cases. So we have an alternative cartridge, an alternative principle that is ILTRA, but with ILTRA, of course, a different design where the mutation now are detected by a different way. Here it's a melting shift in melting temperature, and I don't know if it is important for you to explain this. It may be complex, but what is important to know is that here the principle is not the absence or delay. It's more of temperature, melting temperature, and this might be more specific than the other principle. But for now, we already have two reports where the ILTRA also show false rifampicin resistance, false rifampicin susceptible that doesn't detect mutation. And in field, in most studies, for now, the Xpert ILTRA have same performance as our past or classic experts. So it's really important to conduct more studies, more field studies on ILTRA, and see whether ILTRA can solve this issue of very low. For now, most field studies haven't shown the significance in detection of rifampicin resistant or the benefits. So we hope in Rwanda to initiate an analysis that include ILTRA, and we probably show the results. ILTRA can really can help us to solve this problem, and by simplification also of our flowchart. I think ILTRA can help to simplify the flow or the algorithm, and also using some other technique that we plan to implement. So I thank all collaborators that have really worked hard to get all these results. And thank you for following this. I hope you had a clear understanding of the possible false result on Xpert, and always be doubtful whenever you see the result is not really correlating with your clinical view of the patient. Thank you.
Thanks a lot, Claude. That was great. We have approximately 15-20 minutes for the discussion. So I would suggest that we start with the questions that are already posted in the chat box. And then if anybody else would like to ask a question, please raise your hand, and then we will follow. There are many people saying that they have experience with such false results like Claude reported. So let's start with the first questions. There is a question that asks, could this be possible because of the calibration of the machines and how frequently you calibrate gene expert machines in Rwanda. And I will ask like 2 questions, and then Claude, maybe you could take 2 at once. And the second question was, would you expect a higher proportion of false positive results depending on the setting of the burden of MDR-TB? So would there be a difference between low burden MDR-TB and high burden? So if you could address those 2 questions, and then we move forward.
Yes, thank you, Anita. One thing is that the calibration is not the real cause. We have always the annual calibration, and when the number of tests 2000 reach, they have to calibrate. We have services of the machine. It is not really associated with the issue of calibration, and it is not specific to a given machine. It's a nationwide. It's really an issue of calibration. And we also receive QC for our experts. We receive QC panel from CDC, so it's also annual, and we generally perform well. So it's not really an issue of QC and so on. So the settings, the issue of settings, it is really important, and it is really related to setting. When the population or the prevalence is high, the prevalence, the rifampicin resistant prevalence is higher, then this will not be the same. The proportion will not be the same. So the positive predictive value, the rifampicin resistant, the probability of detecting or having a true resistance when very low, we just vary depending on how many or how often the resistance is there in their population. It is really population dependent proportion. So if the proportion or the prevalence is high, the rifampicin resistant prevalence is high, then this proportion will also be high or will be lower. The false will be lower. So most will be confirmed as resistant, true resistance, because of that. Yeah.
Okay.
Maybe to expand on that, why did we only run into this problem 10 years after Xpert implementation? Has again to do with the pre-test probability, as Claude was saying. So until 2017, microscopy was still the main diagnostic test. And then as Xpert became rolled out, everybody who was diagnosed with TB based on microscopy then had rifampicin DST done in Xpert. So those bacterial burdens were higher. And as Xpert became the universal first test for somebody with presumptive tuberculosis, that's when you also have a higher proportion with a low bacillary burden. And this is really a technical flaw of the Xpert that in the context of little bit of TB DNA, when not all the probes bind, it should say invalid, and it should not say I am missing a probe, therefore rifampicin resistance. But we asked Cepheid if they could modify their algorithms, and that's obviously not so simple. So that has not led to a success. We hope and cross fingers that this melting temperature-based rifampicin resistance calling of the ultra will increase the specificity in the context of low bacillary burden. But as is already mentioned in the comments, we may also have a large proportion of people with TB trace detected, and we don't know about rifampicin resistance. We hope that the culture grows or that we have other means of diagnosing rifampicin resistance. Thank you.
Thank you both. I will move on with the questions in the chat box, but please feel free to raise your hand. It's easier than and also more efficient. So I will go to the question, which is more a clarification question for Mo Pie. I think she would like to clarify what was your gold standard for confirming rifampicin resistance?
Do you want me to answer?
Yes, yes.
So, we used sequencing, but also different sequencing and also phenotypic DST. So where possible, we used the deep sequencing on sample, that is duplex. And we also used Sanger sequencing for some subset of sample. And some others, we used whole genome sequencing. And for almost, we had also culture results. So or phenotypic DST.
Okay. Mo Pie, if this was not enough, please raise your hand and then maybe we could address more. But in the meantime, we can move on. I think Dr. Nimer says that if people stick to this guideline to repeat gene expert, is there still a risk to miss false rifampicin resistance results? And also for those settings, do we need to include a specific probes that are adapted to the prevalence of rifampicin resistance in the setting? I think the second part was already answered by Bauke, which said that this is not very simple, but the first one is if you could address. So the question would be, if you repeat the expert result, are there still risks that you will miss? Actually, that you will still have rifampicin resistance missed falsely.
Yes, that is true. And especially for heteroresistance, especially for those samples with mixed population with low proportion of mutants. And when you test that, it can be RIF resistant. As showed among, we had 10 on which the repeat did not show rifampicin resistant, but subsequent repeats, that means not only a single repeat on the idea. Our initial idea, the initial idea from ARMA was to repeat even not once, repeat 1, 2, 3 with good samples, so that you can maximize the chance of getting even those with mixed population. But the complexity, the more complex, the more challenges. So that is where we are now. Even we want even to make it more simple. And if you repeat, you risk, you still have the risk of missing resistance. That is where you need even to repeat during rifampicin resistant regimen, which we suppress the wild type. Then the proportion of mutant can increase. When you test, the expert will detect it. And sometimes, depending also on the sample, the quality of the sample, you can even miss that is where the expert, when repeat, it gives MTB not detected, because the sample was not such rich to give a detection, to give the positive result. And when you repeat again on the next day, it can give a result. So it is possible to miss the resistance on repeat. Yes.
Okay. I think there are more questions and some hands up, but let's go just through the questions on the chat box first, because they were first posted. There was a comment from Dr. Eve who said that programmatically introducing this algorithm also might be challenging, and it's very important to train the staff how to interpret the algorithm so that you don't end up that some of your cases are treated as drug-sensitive TB, which would be right in this case, but some also not receiving treatment at all because they were still diagnosed with TB. Then a question from Dr. Farzana, which says, which asks, is this in any relation with the sample quality, quantity, and quality of buffer? And I would here sneak peek my quick question because it's very similar. If you test samples where you do expect a lower bacillary load, let's say a gastric aspirate from pediatric samples, would the risk, how would you then interpret the results? So if you could address this question. Sorry, Claude, it looks like your PhD defense, but it's good that we have so many questions, and yeah.
Yes, I'm happy because I see how this is going to save some number of patients from these drugs. They are not good drugs. Then if you can protect your patients from this drug, I'm really happy with that. So at least some number of patients can be saved. Let's clarify on this. Sample quality, it is really key and very important. Having poor sample quality is a problem. So the sample is matter, either from the beginning or on a repeat. That is where, if I see the repeats at National Reference Laboratory, where the sample are more collected in DR clinic, and most are morning, we have morning samples. The repeat at NRL shows a grade, higher grade than the initial Xpert on. So the sample quality matter. So it is important to really clarify, instruct the patient, and possibly have a good morning sample to repeat the Xpert, or even, yeah. So the buffer, the amount of buffer, I think technicians are always trained on that, and normally it goes well. Normally the laboratory manipulation is not complex. It always, if I didn't get it correctly, generally the buffer is not a problem. The technician knows a lot, or knows how to do this, and it is a more simple method.
Okay, and what about the extra pulmonary samples?
No, yeah, until now, no more experience with extra pulmonary samples. In our study, we only used the pulmonary, but what I see is that whenever you have very low bacillary loads, the possibility of that, the rifampicin resistant detected associated with a very low or high CT is likely also a problem. Even if we didn't test this in our study, it's not really something dealing with the material itself, but the template, DNA template in the sample. So when the DNA templates are lower, then the possibility of this false result is a bit higher. So it might be same as sputum, although we didn't test that.
Okay, Bauke?
Yes, just to echo this point about sample quality. Essentially, because this false resistance occurs when there's not enough DNA. If you get a good quality sample and you aim to have more TB bacilli in there, the quality, the specificity of your Xpert RR will be higher. So that's important. And what Claude found in his study is that when he looks at the raw data behind the report, so the screen on the Xpert equipment, and every time that the RR result was based on the dropout of 2 or more probes, it was false. So it's possible that in this region that is the target of Xpert, that there are double mutations. That is not unheard of. So it's possible that you have true RR with 2 probes missing for a double mutation, but that is rather rare. And in his study, all the ones with 2 probes missing were false. So these are, I'm not saying that every time you see 2 probes missing, it's false, but when you have a very low RR and you are in doubt, having more than 1 probe missing makes the chance that it's false resistance even greater.
Okay, thanks, Bauke. We will move forward. I go now to the hands. So I have a Dr. Uvaye. Sorry if I pronounce your surname in a wrong way. I'm sorry. Go ahead. Claude is ready.
Thank you. Thank you for the presentation. Mine, it's like a question and maybe let me just say an observation, because at our facility we tried sending the low, that's MTB positive with low the results that were low, and also previously treated TB patients to the reference lab. They raised a red flag. It was actually already a burden, and this was just one facility out of over 100 in the state. Is there, for the lab people, is there a way that maybe all these studies that are being carried out can be communicated to CFID so that they can bring, produce a more sensitive and specific Xpert test that can help us bypass this? Because with this, if we make it like part of the national algorithm, if you have a low low on the Xpert result to send to the reference or national laboratories, I think it will be like overburdening those labs for high burden countries like Nigeria, India, Myanmar, and others.
Sorry, do you mean you sent very low bacillary load rifampicin resistant or all?
No, all previously, no. Particularly previously treated.
No, normally not. We just say the algorithm starts by rifampicin resistant.
Okay.
Not all.
Okay.
Resistant detected, then you move forward with evaluation of load.
Okay.
High, medium, very low, or low. So that is important to note.
Okay.
Maybe back.
Okay, regardless of whether they were previously treated.
Let me just, because it's also Khalil Sani in the chat.
Okay.
When Claude talks about the low specificity of RR in the context of bacterial very low,
yeah,
it is the specificity of RR. The specificity of TB diagnosis is okay.
Okay, okay.
The 2 false TB diagnoses were on the other end of the Xpert's spectrum. The very, very low CT values, very, very high burden. There was not even TB.
Okay.
Other errors. So this bigger error on the false RR,
okay,
not pulling into question whether these people had TB.
Yeah. Okay.
And the same with the ultra. So Khalil is saying we hear about the ultra having low specificity. The targets that are added in the ultra compared to the classic IS 6110, IS 1801, they are specific and they have many copies. So that's why they are more easily detected than the RPOB gene. So that's when the ultra will tell you trace. And those are TB DNA, but you are mentioning specifically in a retreatment patient. That's where you have to watch out, because they may secrete that bacilli up to 5 years after a successfully treated episode. So then it has a low clinical specificity. But the ultra, when it gives you trace or very low, you can be assured that there was really TB DNA in the sputum. But if somebody was treated 6 months ago, it may be remaining DNA and they are not sick right now with TB. Is that clear?
So, thank you, Bake, for clarifying on this. And this is really the issue which is now in our settings. That is where they will not, they will just consider there is no TB on when they repeat, and that is where the 5 patients end up with no treatment, which is very risky. So the repeat here, or as Bake said, the concern is not TB, is rifampicin resistant detection. So that is the only, and it's quite sometimes difficult to explain, but as simple as we didn't test the issue of TB in this study, the issue of TB is always confirmed with a single expert. The next expert is issue of confirming resistance.
Thank you. We are over time already, but I suggest that we still take the 2 last comments and 2 last questions. And if people have to leave, of course, we understand that it's a very busy time for all. So I would like to ask Dr. Ali to comment and ask the question. The hands is up.
Okay, hello everyone. Thank you, nice to be here again. I think my question, that was just answered when Professor Bock was talking about, you could still have positive results, positive RR results several months after treatment because it's picking DNA. Because that was going to be my questions, that what kind of time lag can we give to expect that a patient should be no longer positive on Xpert? We see a lot of that. And then the other one is on the Xpert Ultra. So we have sort of switched in Nigeria to the Ultra cartridges, but worrisome is that we've seen a lot of reports of indeterminate results, not trace. So Claude mentioned about trace, not trace, but indeterminate. So we tend to get that often, and I wonder what the problem is and what can we do when we get such results. And it's so often. So what kind of algorithm can we put forward to help, with such, issues? But bearing in mind again that it's a very high burden country with sort of limited resources. So we tend to sort of rationalize or ration the cartridges. So we don't have the luxury of sending everybody back for a repeat or a retest, with the experts. And not everyone can also have, culture done and all. So when we have faced with challenges like this, what will be the best way out to ensure that true positive cases are not missed? And then, we're getting everybody on their care. Thank you.
Thank you, Ali. Not sure if Bauke or Claude would like to comment back.
I don't consider myself an expert yet on the Xpert Ultra, but let me try. And thank you, Ali, for posing that important question. So when I just explained, the ultra trace means that the insertion sequences were detected. There is TB there, but there was not enough RPOB DNA to make a call on rifampicin resistance. And what you are describing is indeterminate, where the algorithm in the cartridge says, I am not sure enough of the RPOB result to give you a result. In a way that is good, because then you avoid these false RR. Huh? I wish that the classic expert would say indeterminate when it has not enough DNA instead of saying RR. But then what do you do clinically? I think we are back to the comment on good quality sputum with as much bacilli as possible and crossing fingers that your next result is with sufficient DNA for a proper answer. But that is costing you an extra cartridge and not always feasible. So then maybe if you have indeterminate RR, you know it's TB, you go back to your pre-test probability of how badly do I need a rifampicin resistance result before choosing this patient. Does that help you?
Yes, thank you very much. So that will have to be individualized sort of decisions per patient that you see. And that helps in, you know, arriving at the final step to take. But thank you.
Yeah, I guess we all agree we shouldn't treat the result, but the patient. But sometimes in a programmatic setting, there are challenges, and we very often skip that individualized approach. But maybe it's time to go back to that as much as possible. The last comment was from Parvati, and I will apologize if I missed anybody else. How I understood Parvati's comment was that can we monitor the treatment response by looking at the cycle thresholds, and so by using the gene Xpert? And is that something that Claude was also proposing in his presentation? Parvati, correct me if I misunderstood your text.
So I think Claude mentioned that in his presentation. I was wondering whether that could be adapted to Gene Xpert Ultra also. But I don't know if I understood it wrong.
Oh, sorry. Maybe I mixed. We want to see the ultra whether it is going to really address the issue that we observed with the classic, and with ultra, by same kind of analysis, we try to adjust the algorithm, the way of testing accordingly. It doesn't really say like we did for classic is the same. It doesn't fit. It won't fit. So with ultra, it is something else that we didn't test in our study.
Okay, thank you.
But maybe, Claude, you showed the DIAMA protocol where indeed in work package 2, Claude and others are monitoring Xpert every month on patients on RR treatment. And it is too early to tell you whether that's useful. It is a jagged curve. It can go up and down. You do expect, just like with microscopy, that the burden decreases. And so probably it's most helpful if it goes to 0, that you are encouraged that it is a patient who is responding well, but we cannot yet answer your question on how to use Xpert for monitoring treatment.
Okay, thanks.
I think we need to conclude because we will soon be cut by Zoom, I guess. Sari, should I hand over to you? And thank you so much, Claude. Thank you, Bauke, and thank you all for great discussion and questions.
Thanks, Anita. Yeah, I would like to thank everyone again for joining us. It was a great interaction. Also, Claude and Bauke, thank you for everything. And if you got another subject or topic you want to discuss, or you got a case study or paper, feel free to contact me or Anita, and we will see if it's able to do a Zoom meeting like this. There will be one more left that we're already preparing, but if you got other subjects, please contact us.
Yeah, you still have some time to change the last, well, not the last, the next one subject. Parvati, I know what you have suggested.
I wasn't good to hear anything.
Okay, thank you.
Thanks, everyone.
Thank you. Bye-bye.
Thanks,
Bye-bye.
Claude.